here at the American Academy of Clinical Psychiatrists update for 2015. Dr. Rothstein, it's really good to talk to. I really appreciate you making time. And Dr. Rothstein is an expert on, well, both pediatric psychiatric concerns, because were you actually a pediatrician at one time?
A pediatrician, then a child psychiatrist, and I also practice with adults. I call myself a lifespan neurodevelopmental psychiatrist.
That's great. You are familiar with the concerns that primary care doctors are confronted with,
exactly,
both in the pediatric realm and in the adult realm. We're talking about adults, so when an adult comes in and presents with signs that seem suspicious for ADHD, what are they going through? What are you looking for? What kind of signs are there for you, and how do you start to think, I'm going to make this diagnosis?
Well, I think the primary complaint we see in our patients is difficulty staying focused and getting things done, and feeling very frustrated that no matter how hard they try, things never really come together.
Is this a lifetime, or is this something that
it's something
develops?
that's bothered them for a while, but finally it's become really serious.
Mm-hmm.
So they may be losing a job, they may be having marital trouble. We often see in the adult world, someone says, oh, my child was just diagnosed with this, and now I realize the same is true of me, continues to be true of me. And again, we also see people who come to psychiatrists being treated for depression or for anxiety, and for some reason, even though they're on the right treatments, they're still feeling unfocused and unable to motivate.
Mm-hmm.
So with those individuals, we suspect that what's happened is that they've had unrecognized ADHD their whole lives, and now they're finally ready for help. The other big group in the primary care office would be the people who seem to have trouble adhering to, say, treatment for their hypertension, people who fail out of smoking cessation programs, people with eating and weight problems who
just
can't
simple
lose
non-compliance,
weight.
or it seems like non-compliance?
Well, for example, no, they're trying to do what's being asked, but they keep forgetting.
Oh.
Okay, so forgetfulness,
All right.
and forgetfulness in every realm of life is one of the most common symptoms of adult ADHD.
Oh, so that's interesting. So they may present and wonder if, let's say, they're in their late 40s or their early 50s, and they present, they may wonder if they're actually becoming senile,
right.
but really
and
it could
say,
just be
oh,
ADHD?
I must be getting dementia or something like that.
Interesting.
And what will happen is that they will say that they will be talking to somebody, and they'll say, you know, I went to a movie and I just don't remember what it was about, you know? And again, not to jump to any conclusions, the complaint of trouble remembering or easy forgetting is something that I would still perk up my ears and not think immediately dementia, but maybe this person's having attention problems that were never recognized before.
Interesting, but then wouldn't they have had memory deficits or cognitive issues prior? I mean, it sounds like what you're describing is late onset.
Well, what we're saying is that the complaint itself should be traced back.
Okay.
And then you sort of go back and say, now, was this true before? And they might say, yes, it was true, but I was able to, I had someone like at my office who kept my time management. Now I'm in a new place.
Okay, all right.
So when people shift environments and they start to work in a new place, or they start a new relationship, that they might get feedback from that individual that, gee, you know, you're not paying attention to me. Like, I'm talking to you and your mind is somewhere else.
Mm-hmm.
What's going on? So all of those are just clues. I'm still talking about clues, not a diagnosis, just when maybe on your differential, when you hear someone say, you know, I'm really not getting where I need to be. I'm working hard, I'm always late. Or I'm working hard and I'm staying up too late. Or I'm spending too much time on my computer and I can't pull myself away. Right? Does that mean they have ADHD? No, just a clue they might. And then once you talk some more, you always ask the question, was this a problem when you were young? And if it was, may not have been as impairing. So what happens is that people have had the symptoms for a while, but it wasn't causing impairment. And I think where the rubber meets the road for us in clinical medicine is that when we see patients who are having impairments in their daily functioning, it behooves us to really work them up and see whether or not they have ADHD.
Okay, so then Let me just make sure that we recap that then. So then if a primary care doctor in particular is seeing somebody who's complaining of a variety of what seem like cognitive types of functions, the differential definitely should include ADHD.
Absolutely.
And
Any
then,
kind of executive function difficulty,
okay.
trouble managing time, trouble dealing with complex projects, trouble with sequencing, trouble with self-regulation of just like keeping their emotional balance, excessive stress for no reason, unable to keep a goal in mind even when there are distractions because you tend to get off track easily. All of those are what we call executive functions, and people who are experiencing that may not be ADHD, but that should be on the list.
Okay, so then if that is the suspicion of the primary care doctor, is this something that they can treat themselves, or should they immediately refer? You know, I don't know, what is the best situation?
Well, from the primary care physician standpoint, we now have very effective tools. We can look, using those tools, you can get a better handle on whether this person deserves an ADHD assessment. It's not a 5-minute deal, okay? So in the primary care setting, it would be good to be familiar with the screening instruments, then to give the patient a packet to fill out in the waiting room that goes more in depth.
Okay.
And then using those tools, I think a primary care physician can diagnose an uncomplicated patient with ADHD who's never been diagnosed before. Now, they may want to refer the person for confirmation diagnosis,
right.
Consult with a psychiatrist, but I think that, like for example, someone who comes in and says, you know what, a mom who comes in and says, you know what, my child was just diagnosed by her pediatrician with ADHD, and I really think I have this, then it's very, I think a pretty straightforward, you know, it's not about getting to yes or no right away. It's exploring what's going on with the patient, giving them some tools to fill out, screening tools and questionnaires, and then going through a structured diagnostic interview that a primary care physician can learn. We actually have a website that teaches primary care physicians how to diagnose ADHD, and you can get CME credit, okay? And there's world experts in adult ADHD. A couple of them are family physicians themselves who can really present in a very structured way how you get at the key questions to ask,
okay.
and how to make sure that you understand impairment, and to be sure then, if that is the case, how to begin the process of helping the patient. And medication may fit into that.
Right.
But I think all of us believe that pills don't teach skills. So patients with ADHD need to learn how to restructure their lives, how to learn to say no to things, how to understand which environments are most distracting, and how to address those distractions.
Interesting.
Healthy lifestyle, sleeping, eating, exercise, you know, having a chance to reduce stress. And then beginning to think about this. ADHD isn't a disease. Okay? It's a difference in your nervous system that leads you to be more prone to get off track, or to be impulsive, or to just lose focus. And given that, once that knowledge is in the patient's hands,
yeah.
we really think about this as a collaborative exploration of, okay, let's talk about how ADHD affects you, in which areas in your life is it most impairing, and then let's look at all the treatment options. Okay, once they've gone through a workup, and once they've gone through what we call basic self-education.
I'm going to just back you up a little bit.
Sure.
And we'll get to the psychoeducation sounds extremely important.
Yeah.
But that's really maybe a revolutionary thought, that it's not a disease, it's, well, then what is it? I mean, because
we call it a neurodevelopmental disorder,
okay.
which means that it's, in a sense, it's something you live with your whole life, which is affecting everything you do.
But it's chronic then.
It's chronic.
But it's not a disease, it's a disorder.
Correct. Which means, another way to think of it is, say, do people who have poor eyesight, do they have a disease, or is it just that they have to learn how to wear glasses and
so
how
that
to
helps
adjust?
destigmatize it, I would
totally.
imagine. Yeah. Okay.
Yeah. When first thing I say to a patient when they have ADHD is, I say, listen, let's talk about what it is and what it isn't. It is not a disease, and it doesn't have to be incapacitating.
Okay.
But it does present you with challenges, because it takes you longer and it is harder for you to reach the goals that you have because your brain is not working as efficiently as other people's. So as a result, you may not only take longer to get where you need to go, but you may get off track more often, and you may actually feel exhausted by the end of the day when other people around you seem to be fine. You know, people with ADHD typically talk about by the time they get home from work, they're done, right? They're done. Well, now they have to be a member of a family, hanging out with their spouse or their kids, and their brains are just like tired. So helping people to understand that it's something you have to understand how it affects you, how it changes the way you need to think about the way you deal with the demands on you.
Well, usually,
and reorganizing your life.
It sounds like, I mean, that's almost like in the pop culture. Oh, I'm just so stressed out. The day really got to me that it just seems as though maybe it's environmental. It doesn't necessarily seem like it's clinical. But you're actually suggesting people need to think of it both.
Right. So what I would say is it's about the fit between the personal and the environment. Okay. So if we think about attentional capacities or executive functions, they're on a continuum, and so it's not like either you do or don't have ADHD. It's really about how much is your brain not working up to its potential or not able to handle what we would call normal everyday demands. And if it's just a little bit off, you might just have some of the symptoms but not be impaired. But the more off it is from what it ought to be, the more we would be comfortable saying, yes, you have the clinical diagnosis. But what's fascinating about ADHD is that by the time we see adults, many of them have accommodated to their disorder. They've used compensatory strategies. They'll pick jobs that are less demanding. They'll pick a partner who's very, very well organized and keeps them on track.
And they thought it was just love.
Well, it is love too, but it's longer lasting because it's a positive interaction between the two. They will have avoided situations that are hard for them. So many of them say, drop out of college and never finish.
Let me just stop you there and say, this is why I think it's hard to diagnose it, is because people often just think, don't pathologize my life, because this is just me, this is my personality, this is who I am, this is how I got made, and here's how I live my life as a resort. Because people do create coping strategies.
I have an anecdote for this.
Okay, good.
One of my first adult patients with ADHD was a man who was a physician's assistant, and he was working real hard to make it through his job. He had struggled through PA school, was working as in a very high stressful environment. And he came in, and we did in fact identify, and we treated him. But at one point he came to see me, and he said, Dr. Rothstein, I can't tell if I have ADD or if I am ADD. And I said, that's a remarkably profound question. Do you have something, or is this who you are?
That's a great question.
And so what I basically said to him was, it's a little bit of both. Okay, you have a disorder, your brain is different than other people's. Not so different that you're psychotic or you're seeing the world through completely different lenses. But it is different on the one hand, so it is a disorder. And yet it is also, to some extent, it's who you are because you've lived with it your whole life.
Right, exactly.
And so I don't want to pathologize. Occasionally we'll see people who we can diagnose with ADHD who basically just say to us, well, thanks, but I don't really want to buy that diagnosis. I'm just the way I am. And we're not going to argue with that person. We're going to say, okay, fine. If you're willing to entertain the diagnosis as something to help you map a strategy for making your life better, then that's what we would like to offer you. It's a way to help you to make sense of how your life hasn't gone the way you wanted it to, instead of blaming it on you being lazy or you being angry all the time or morally weak or somebody who's dishonest. I mean, we see a lot of compensatory strategies that people with ADD have developed over the years that are not good. Okay, they may drink too much or use substances. They may lie to cover up their difficulties. They overcommit and then they bail out, or they overstimulate themselves and can't ever learn to relax. So all of these behaviors we think are rooted in the combination of the biology of ADD and the individual's psychology, how they adapt to their ADD, along with the social environment. What were the opportunities? What were the options they had? What were the choices that they could make? And that's where we say it's a biopsychosocial disorder. It's not just your biology or your psychology or your environment. It's all of those together.
Wow, that's really exciting. Okay, so now I don't want to lose my train of thought here.
Sure.
But I am actually thinking this is a great seg back to the idea of psychoeducation, because if you can get a person to understand this is who you are. You are ADD, you are afflicted, or you're affected.
You're affected and you are an ADD person. That's right.
So, and that just is. There's no value, judgment in that. Okay. So then, and here's how we can help you cope. What do you think?
That is the goal. The goal is resilience. It's not eliminating ADD. It's learning to live with it and becoming resilient.
But getting them on board with that attitude then brings me to something that is now kind of nascent. I don't know, maybe it just seems nascent to me in the literature across all of the psychiatric disorders. When you can involve the patient in their treatment plan and get their feedback before they start their plan,
that's essential.
You end up with better outcomes.
Well, it's essential. We cannot make an impact on this disorder without buy-in from the patient and without a relationship that makes sense, in which two people can talk honestly together about the challenges. We don't want to pathologize the patient in the sense of making them feel even worse about themselves.
Right.
Nor do we want to say ADHD is an excuse for why you don't have to work hard. Okay, so it's neither you're like, forget it, you're hopeless, which is what I think a lot of people are afraid of. I think what happens to them is they don't want to come in to get the diagnosis because they're afraid, like, oh, it's going to tell me that I'm a hopeless case. But on the other side of the coin, we don't want to give the message to patients, oh, because of your ADHD, you got a free pass and you shouldn't learn how to take care of your life. What we say instead is, this helps you to calibrate and to redesign your goals, your environment, and the tools that you need to succeed. It's not up to me to tell you what success is. You have to figure out what success is, but you have to factor in your ADHD. And it's more, we do a lot of motivational interviewing in the early stages because we use psychoeducation, but not in a lecture as much as to say, what do you think is important to learn about? And then when you've read something, come in and talk about it. Like, someone came in the other day and said, well, I just learned a lot about like diet and needing to eat differently. Mm-hmm. I said, okay, if you're interested in diet, let's talk about how does diet affect people with ADHD? What are the better things to eat, what are not? And that's where we begin, not because they were not interested right off the bat in medication.
But if I'm the primary care physician and I only have 15 minutes to see this person, it can be very difficult to have a conversation that's more about, well, what can we do to collaborate on this, instead of, okay, here are the things that you can do, let me check off the list. Mm-hmm. And they may or may not even include medication. It may be behavioral. So how can they, what do you do?
So the best thing a primary care physician can do is to identify the ADD resources in their community.
Okay.
These are organizations, self-help organizations like ADA and CHAD. They also need to identify the professionals in the community who are, say, ADD coaches and people who are mental health providers, so that you can say to the patient, listen, I'm not going to be able to do all this for you, but here are a set of resources for you. Go and look at them and come back and say what you learned. And so for some people...
will they do it?
Yes,
or will they forget?
Go online. No, they will go online and they'll come back and they'll say, I watched that video, I saw Dr. Rothstein, he made a good explanation of what it was, and here's my question. Okay. So then the physician and the patient begin to identify the resources that are going to keep the patient moving forward. Then if there's a decision made to start a medication, similarly, what's going to be the expected feedback you're going to need as a person prescribing?
Right.
Who else besides the patient can supply that information using rating scales? We're moving more and more now into being able to have patients record their responses, on their cell phones.
They can even do it before they come in.
And then when they come in to the office, they know, before I sit with Dr. So-and-so, I'm going to fill out a form, and then the doctor will be able to compare how their symptoms were before and after. That doesn't take a lot of time. You know, you only have 15 minutes, but if you, within those 15 minutes, A, you have some data that the patient is bringing you, B, you have a set of questions that you want answered, and then the two of you together at the end of it decide, okay, are we moving in the right direction with this approach, with this medication or not?
Well, you know what, if I'm a primary care doc and I hear you saying all these things, I might actually start to feel more relaxed about being able to deal with this then, because I know that there are so many frontline physicians who just feel overwhelmed anymore, particularly with mental health issues,
yes.
You know, one way or the other, whether it's a disorder or disease or whatever, because they have to treat so much that in the past maybe they didn't either learn about in school, or now it's on their doorstep more, either. And a lot of it is because there's more awareness of things like ADHD. So if I'm hearing what you're saying, you don't have to be scared about this. There are so many tools available, and there are resources.
Right. So I think the family physician needs to feel comfortable with what is the diagnosis and how to make it.
Okay.
What are the challenges that most patients face? What are the resources out there? And finally, helping the patient prioritize the goals for treatment and the indicators of progress. You can't do it all at once. So I had one patient said to me, "Doc, I just want to be able to come home and sit and play with my kids without being able to lose interest or to get frustrated." So for that person, that was where we concentrated. Whatever I'm giving you, you'll have to take it later in the day when you come home.
Oh, okay.
And we will then ask the question, is it easier for you to do homework with your first grade son who also has ADHD? Are you able to be more patient? I had another patient who said, I just want to be able to read a book. So again, if you turn treatment goals into concrete objectives, instead of saying, I want to focus better, it's, I want to focus long enough that I can read a book. All right, and then at that point, you can say, okay, if we're going to start this medication, that's what we're going to focus on. Is this helping you to get to read a book? Okay, and then you move down the list, because I imagine for a family physician, if the patient also is having trouble with sleep, then you want to make a focus on sleep. If they're overweight and they're not losing weight, maybe the medication can help them follow a diet
Okay,
better.
so do you automatically start with a medication? Because if the goal is just simply to read a book, you don't take a pill to read a book.
Well, for some patients, they cannot read a book without having a medication.
Okay, so
that's what I'm saying. If they've tried the other strategies and nothing is working, okay, we bring medication in after we start with education, environmental restructuring, and supports or scaffolding. Okay, those are the key. Education, some form of restructuring how you live your day, reducing the demands at the wrong times of day, or just time management, and finally, a coach who might help you implement that. After all that is said and done, if the patient says, look, I'm doing all that, but you know, when I still sit down to read, my mind is everywhere, I cannot read. That's when I would say, yeah, let's see if a medication can help you read, or let's see if a medication can help you calm down that motor that doesn't calm down.
But what are the most salient things that a prescriber needs to know about the different medications for adult ADHD?
Right. So first, let's start off with the idea that you have to trust your patient has to trust you, that if you're going to prescribe a medication, you have an agreed upon way of measuring its impact. Okay? And that the patient's responsible for letting you know that they're taking it. If they're not, why not? What's interfering with the adherence side? And then if they're taking it, what are they noticing? Right? If they can they can pay attention to their own attention, then that's the goal of the discussion, is did this affect how you did A, B, or C? So you want to be concrete, you want to have easy to use scales, so again, you don't have to spend a lot of time. All right, now, if you're going to use a medication, you should be familiar with the medications. So you need to know how the medications work, how do the stimulants work, how do the non-stimulants work. What, in fact, would be important to ask at that point is, what does the patient prefer?
Back
because
to that
some
again,
patients will say, I
I
really don't like the idea of medication, and you know what? Stimulants really, not for me. Others will say, no, I really would like to try a stimulant. And therefore, you don't try to tell them, no, I won't prescribe you a stimulant. You kind of work at the patient preference level. And then you review the data with them and say, okay, if you're comfortable with the stimulant, here are the two types, the kinds that are the methylphenidate or the amphetamine types. They come in different duration of action. Maybe it's better to start with long-acting for you so you don't have to remember. And then you begin to build a plan, right? And the most important thing, and this is what we all need to really take with sort of great seriousness, is each time we start a medication, it's a trial of a medication. It's not known before you try it whether it'll work. So I always say to the patient, I don't know if your brain will respond to this molecule. We're going to use this molecule for this reason. It's going to come in this form. You know, it works this way. And if this molecule is or isn't going to help you, we need to try you on a variety of doses. So we'll have a starting dose. If that works, great. If not, we'll move up. It's trial, a rationale for the medication choice, and a strategy for we call sequential medication titrations. And you can go up or down. And the analogy I use totally, it's exactly the same for the benefit of any family physician listening. It's like antihypertensives. You don't know off the bat what's going to achieve normal tension. You know what you're aiming for, a blood pressure that's, a target blood pressure, diastolic below 90. Okay, fine. There's really not that big a difference between treating ADHD using these medications and treating any other chronic disorder. Because if you don't take that systematic approach, A, you won't get the kind of results you're looking for, and B, the patient won't stay on the medication.
So, okay, then physicians should not be nervous about this.
No.
As long as they are continuing to communicate and collaborate with the patient.
Exactly.
And the point I really did want to stress was that you get better outcomes when you've taken into consideration as one of the clinical symptoms, actually, what the patient wants. For example, if a patient says, I really don't want to be on a stimulant, and then you prescribe a stimulant, guess what? You're probably not going to get good outcomes. And, or any combination like that.
I mean, so patient preference is important, patient goals are important, and then embedding the medication usage in a realistic kind of set of expectations, meaning you don't want to overpromise. Medications are tools, but pills don't teach skills. So what I believe a medication does is it enables the brain to work a little more efficiently, and therefore if the patient needs to learn things they haven't learned, there is a better chance they will learn them. If they've learned things but they had trouble implementing them, it'll be easier for them to implement a plan that they've developed ahead of time. Because they'll be less distracted, they'll be more able to stay focused on their goal, and there'll be less inefficiency or better energy expenditure in the pursuit of those goals.
You kind of level the playing field for them.
Hopefully, that's the goal.